In this section, we'll be talking about different types of control of the cardiovascular system. In this section, entitled Control of the Cardiovascular System, we'll discuss some specific mechanisms the body uses for control of hemodynamics. Blood pressure in the body is very tightly regulated. There is a narrow range of conditions that we need to keep for survival. The control mechanisms that we have are multiple, including humoral and neural factors. Humoral factors involve the production of circulating molecules that can affect the dilation and the constriction of blood vessels. Neural control mechanisms generally involve the sympathetic nervous system, including epinephrine, acetylcholine, and so forth. Let's talk briefly about endocrine control of blood pressure. One of the most important molecules in our body for endocrine control of blood pressure is ADH, or antidiuretic hormone. This is also known as vasopressin. ADH is released from the posterior pituitary, but it's generated in the hypothalamus. ADH is released in response to increased blood osmolality. ADH acts on the kidney by causing reabsorption of water back into the bloodstream from the urine. ADH does this by increasing the amount of cyclic AMP present in distal tubule cells. This causes the movement of aquaporin channels from inside the cell in storage granules to the kidney tubular membrane, and these aquaporin channels allow pure water to move back from the urine into the bloodstream. ADH itself is also a potent vasoconstrictor. The renin-angiotensin-aldosterone system is also very, very important for blood pressure control in the human. The RAS system also regulates electrolyte composition as well through aldosterone. The way the RAS system works is by decreased blood pressure stimulating the release of renin from the kidneys. The juxtaglomerular cells, which are modified smooth muscle cells, will release renin after a signal from the macula densa tells them that the body is having a decreased kidney perfusion pressure. Renin is an enzyme that converts angiotensinogen to angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by ACE, or angiotensin converting enzyme, which is located throughout the body, but mainly in the endothelial cells of lungs and kidneys. Angiotensin 2 is a potent vasoconstrictor. It causes vasoconstriction of capacitance vessels and resistance vessels. Angiotensin 2 also stimulates the release of aldosterone from the adrenal glands. Aldosterone works on the distal tubule of the kidney to reabsorb sodium and water back into the bloodstream from the urine. Atrial natriuretic peptide, or ANP, also known as atrial natriuretic factor, or ANF, is a protein that's located in the atrial cells of the heart. When the atrium is dilated or distended because of increased fluid retention, this ANP is released. ANP goes to the kidney and causes increased excretion of sodium and water by the kidney. This reduces blood volume and blood pressure. Atrial natriuretic peptide is commonly elevated chronically in patients with left heart failure. Neural control is also very important for maintenance of blood pressure. The central nervous system is the integrating center of the cardiovascular reflexes, and the central nervous system controls the autonomic outflow to the heart and blood vessels. The most important way that the central nervous system controls blood vessels is through the receptors that measure pressure in the blood vessels. These are also known as baroreceptors. Baroreceptors are pressure sensors that are located in the walls of the carotid sinus and the aortic arch. Baroreceptors are able to sense heart rate, blood pressure, and pulse pressure. The baroreceptors increase their signaling to the central nervous system as blood pressure goes up. The baroreceptors in the carotid arteries send a signal to the glossopharyngeal nerve back to the brain. The aortic arch baroreceptors send a signal through the vagus nerve to the brain. Both of these baroreceptors then cause an increased vagal output, or a vagus nerve output, that releases acetylcholine onto the heart, causing the heart to slow down. The sympathetic nervous system is responsible for the activation of alpha receptors. Alpha-1 receptors respond very strongly to epinephrine and norepinephrine. When the body is in fight or flight mode, epinephrine and norepinephrine are released. This causes peripheral vasoconstriction, especially in organs such as the viscera. Beta-1 receptors are present in the myocardium, and beta-2 receptors are located in the lung and skeletal muscle. As epinephrine binds to beta-1 receptors, it causes positive inotropy, which increases cardiac output. This increased cardiac output is shunted through beta-2 receptors, causing vasodilation in skeletal muscle. The cardiac output goes to the skeletal muscle because those blood vessels are dilated by the beta-2 receptors, which also respond to epinephrine. So therefore, the effect of the entire sympathetic nervous system is to cause vasoconstriction in non-vital organs, such as the viscera and the kidneys and the skin, to increase cardiac output through beta-1 receptors, and to dilate the blood vessels in the heart and the skeletal muscle, so that we're able to enact a sympathetic response to a threat. The parasympathetic nervous system primarily acts through the vagus nerve, and the vagus nerve does have innervation to the heart, causing a slowing of the heart rate, especially at the sinoatrial node and the atrioventricular node. This decreases cardiac output and lowers blood pressure. The vagus nerve also does have some innervation of peripheral vasculature. This vagus nerve stimulation often leads to nitric oxide release from endothelial cells, causing vasodilation indirectly at the level of the smooth muscle in the arteriole. This diagram shows the location of baroreceptors in the carotid sinus, in the aortic body, and the aortic arch. This diagram illustrates fight or flight. In response to exercise at the top of the graph, we have increased sympathetic outflow and increased local responses. The sympathetic outflow, as we mentioned, through the beta-1 receptor causes an increased heart rate, increased contractility, and increased cardiac output. This also causes a constriction of arterioles in certain organs such as the abdominal viscera, kidneys, and skin. It also causes constriction of the veins. Venous constriction causes increased venous return. Together, this causes increased skeletal and cardiac muscle blood flow because of beta-2 receptors causing vasodilation in skeletal muscle. The local responses in skeletal and cardiac muscle, such as adenosine, cause decreased resistance in those tissues, again improving cardiac muscle blood flow to those areas. The renin-angiotensin-aldosterone system is initiated by decreased renal perfusion pressure. As mentioned before, the juxtaglomerular cells will release renin, which is converted from angiotensin-agent to angiotensin-1, which is converted to angiotensin-2. Angiotensin-2 has two major effects. It causes direct vasoconstriction at the level of the arteriole, causing an increased total peripheral resistance. It also increases the release of aldosterone, which causes sodium and water reabsorption. The end effect is increased arterial pressure. The renin-angiotensin-aldosterone system is a very common target for antihypertensive medications. This diagram is meant to show that the control of arterial blood pressure and blood volume is very complicated. However, if you break down these different systems, you can see that individually they're not so complicated. Here's a common system that we see in patients, especially those that are elderly. When patients stand up, blood pools in the veins in the legs. This causes a temporary decrease in the venous return. This causes a decrease in the arterial pressure. As venous return decreases, so does cardiac output. A decreased cardiac output causes a decreased arterial pressure, or PA. Baroreceptors are able to feel this decrease in the arterial pressure, and the baroreceptor then generates an increased sympathetic outflow using the sympathetic chain ganglion. Increased epinephrine and norepinephrine in the heart causes an increased heart rate, increased contractility, and increased cardiac output. Epinephrine binding to alpha-1 receptors causes constriction of arterioles and an increased total peripheral resistance, and constriction of veins as well, leading to increased venous return. All of these serve to increase the arterial pressure back to normal. If a person has damage to the sympathetic neurons, such as a person with diabetes, they're not able to generate this increased sympathetic outflow, and they're not able to sense the decreased blood pressure from the baroreceptors. These patients would develop orthostatic hypotension. Another important thing to remember about exercise is that it increases systolic pressure, as you can see here, from 110 millimeters of mercury to 145 millimeters of mercury, but generally does not change diastolic blood pressure. It will increase heart rate and stroke volume. It does not change arterial PO2, but it will change venous PO2 from 40 millimeters of mercury to 25 millimeters of mercury as the body uses more oxygen during exercise. This ends our section on control of the cardiac system. In our next section, we'll be talking about hemodynamics and different components of the vascular system.